All right, good afternoon and welcome to this month's Education and Training webinar, Alzheimer's and Brain Awareness, hosted by the Bureau of Chronic Disease Prevention and Healthcare Access, branded as Well Ahead, Louisiana. Well Ahead, Louisiana is housed in the Office of Public Health within the Louisiana Department of Health. I am Tiffany Treadway, Communications Officer for the Bureau, and we are glad you all have joined us this afternoon. We have an awesome presentation for you today with two dynamic keynote speakers. At the very end of today's webinar, we will have a question and answer segment. At that time, you can drop any questions or comments you may have in our chat, and one of our team members will acknowledge you accordingly. But before we begin, let's hear from our Bureau Director, Ms. Avis Richard.
Good afternoon, everyone, and thank you for joining us today as we continue our series about chronic disease conditions in Louisiana. Today, as Tiffany stated, we have two dynamic speakers, two dynamic subject matter experts on Alzheimer's disease and related dementias. Alzheimer's disease is one of the most commonly diagnosed form of dementia in our healthy aging population. And today we're going to learn more about its causes and risk factors, symptoms and diagnosis, treatment, and even caregiving associated with Alzheimer's disease and related dementia. Back to you, Tiffany.
All righty, thank you, Avis. Our very first keynote speaker today is no stranger to the Well Ahead family, Ms. Julie Knight. Julie brings a wealth of knowledge and experience with Alzheimer's disease and grant writing to the Well Ahead team. She currently leads the Healthy Aging Program and Louisiana Alzheimer's Coalition, a deliverable of the Building Our Largest Dementia Bold Infrastructure Grant activities. Julie led the strategic planning process for drafting and developing the Louisiana Alzheimer's Disease and Related Dementia State Plan, which was published in March of 2023. She is currently leading the Louisiana Alzheimer's Coalition in implementing Alzheimer's disease and related dementia state plan activities. Prior to her work with Well Ahead, Julie has previous experience managing Alzheimer's respite centers and leading community-level education, support, and outreach programs. She has also previously served on advocacy coalitions to advocate for individuals with Alzheimer's disease throughout the state. Julie was recognized by the Alzheimer's Foundation of America, the AFA, in 2010 as the AFA Dementia Care Professional of the Year. She holds two master's degrees, an MBA from Louisiana State University and a Master of Health Studies from Southeastern University. Without further ado, let's give a great big virtual round of applause for Julie Knight.
Thank you so much, Tiffany. Thank you for joining us today, everybody. I'm so excited to be able to share this valuable information with our team. If you can advance my slide, Tiffany. Okay, great. So I want to begin today and discuss Well Ahead Louisiana and give you a little background about our Bureau. Well Ahead Louisiana is the Bureau of Chronic Disease Prevention and Healthcare Access arm of the Louisiana Department of Health. Well Ahead Louisiana drives collaboration through our state and connects communities to tools and resources that can improve the lives and health of our residents, where they live, work, learn, play, and pray. Our mission is to connect Louisiana's communities to a healthier future, and our vision at Well Ahead Louisiana is to reduce the burden of chronic disease and assure access to quality health care for all of our residents in Louisiana. Next slide, Tiff. So today I'm going to leave you with some learning objectives. After the session, you should be able to provide an update on the recent legislation passed for Alzheimer's disease and related dementias, understand the importance of prevention, identify risk factors associated with Alzheimer's disease and related dementias, examine risk reduction and preventing Alzheimer's disease and related dementias, and review current diagnosis and treatment and early detection of Alzheimer's disease and related dementias. And also, we didn't want to forget addressing other causes of cognitive decline. Next slide. So Before we get started on risk reduction, I wanted to discuss some legislative updates from this 2024 legislative session. 2 new bills have been enacted into law. And moving forward, we're going to discuss the first act, which is Act 121, excuse me. Act 121 creates the Alzheimer's disease and related dementias advisory council within the Louisiana Department of Health. The governor-appointed council shall consist of 22 members. The members have representation from various subject matter experts, including state, health departments, state agencies, primary care providers, caregivers, care facilities, community-based organizations, law enforcement, academic research institutions in Louisiana that do conduct dementia disease research. The council has many roles, and the council's various roles include conducting a review and assessment of the current status of Alzheimer's disease and related dementias in our state. And we do this by addressing trends in the state's Alzheimer's population and also looking at the needs. This includes existing policies regarding dementia and also examining program utilization among people living with dementia. The council will submit summary findings of the review of the assessment to the Louisiana Department of Health and also review the existing 5-year statewide plan to address Alzheimer's disease and related dementias. These recommendations will be submitted annually, and they'll address topics including gaps identified in the review and assessment, access to care, support, and treatment, quality of care for individuals living with dementia, risk reduction, early detection and diagnosis, and coordinated statewide response to Alzheimer's disease and related dementias. Next slide. So I want to talk about our current state level work. Currently, the Louisiana Alzheimer's Coalition is spearheaded by the Well Ahead Louisiana Healthy Aging Program. The Louisiana Alzheimer's Coalition is led by an executive team, which includes the Alzheimer's Association Louisiana chapter, the Office of Aging and Adult Services, the Governor's Office of Elderly Affairs, the Office of Behavioral Health, Xavier University, Tandem Research, Ochsner Health System, and LSU Health Science Center, Shreveport. Member organizations from various sectors also are a part of our coalition, which include community-based organizations, state agencies, primary care providers, research institutions, educational institutions, health systems, and many more representative subject matter experts. Partnering organizations serve on the coalition to help drive the work that was created within our state plan. The coalition implements state priorities through 4 specific areas: education and empowerment, which addresses risk reduction, early detection; ensuring a competent workforce, which examines training the emerging workforce; policies and partnerships. Policies and partnerships creates community clinical linkages. We also look at advocacy efforts and legislation. And then monitor and evaluate, where this group specifically increases data collection and surveillance within LDH. Next slide. So I want to talk about strengthening Louisiana's response. We now have an ADRD council, as well as the Louisiana Alzheimer's Coalition. And I'm going to go over some high points where these 2 groups exist to work together to implement state level priorities. The Alzheimer's Disease and Related Dementia Advisory Council will help create sustainability among partnerships statewide. The council will provide guidance to the coalition. The coalition will have information among a wealth of knowledgeable individuals who will serve as subject matter experts and provide connections to increase the usefulness of the coalition's work. The council will also make recommendations of the existing 5-year statewide plan to address Alzheimer's disease and related dementias and conduct an annual review, as I mentioned previously. The actual council will improve sustainability beyond grant funding and provide official reports on the progress of our coalition to the governor and state legislature. Now let's examine the coalition. The Louisiana Alzheimer's Coalition will continue to execute its strategic plan to reduce the impact of Alzheimer's disease and related dementias in Louisiana by educating and advising patients, caregivers, and the public. Also to establish partnerships and enact policy changes to ensure we do have a competent workforce, and also looking at data efforts to evaluate and monitor statewide work. The coalition will also continue to be responsible for accomplishing CDC BOLD-funded grant deliverables. Next slide. So I want to take a step back a moment before I introduce this next piece of legislation. In the regular session, Louisiana Legislature regular session of 2021, Act 73 was passed. This legislation was passed to provide education, early detection, and rules that the Louisiana Department of Health can pass. The Louisiana Legislature intent of the legislation passed is to leverage existing health programs and services to educate healthcare professionals on early detection, timely diagnosis of cognitive impairment and dementia, and increase understanding and awareness of Alzheimer's disease and related dementia. Also to provide access to guidance and education programs for healthcare providers. Next slide. So now I want to talk about the second piece of legislation, Act 376. This was passed to amend and reenact Act 73. This act is relative to support services for individuals with dementia to provide Alzheimer's disease and related dementia disease training. This act requires the Louisiana Department of Health to educate providers on dementia services and care, and to require services from public health outreach programs. The Louisiana Department of Health will provide Alzheimer's and related disease training and existing programs, which currently is under our BOLD grant funding. And I'll explain that very soon. Next slide. So in July of 2023, Well Ahead Louisiana received the next round of BOLD grant funding, which is building our largest dementia infrastructure at grant funding through the CDC cooperative agreement. And this agreement was funded for 5 years of implementation to conduct Alzheimer's disease and related dementia activities that are in line with our 5-year state strategic plan that was developed by our Louisiana Alzheimer's Coalition. Priorities outlined include expanding Well Ahead Louisiana Healthy Aging Program further, increasing awareness and understanding among the general public, including populations of high burden, providers, and other professionals about Alzheimer's disease and related dementia topics. And this actually corresponds to prevention at all levels. It also addresses the social determinants of health to achieve health equity goals, improve community clinical linkages among healthcare systems and existing services, public health agencies, and community-based organizations, and also to increase data collection efforts to inform our program delivery. Slide. So let's discuss some successes and accomplishments that have been obtained over the last 3 years. The Louisiana Alzheimer's Coalition created a 5-year Alzheimer's disease and related dementia state plan. And also another big success is the Healthy Aging webpage creation and development. Resources and online tools have been provided. Statewide trainings have been implemented. Well Ahead Louisiana and the Office of Aging and Adult Services have provided trainings to providers and other healthcare professionals. Over the course of May to September of 2023, 712 primary care providers have been trained, emerging medical students, emergency service staff, and also other healthcare professionals, which include direct care service workers. These trainings were held in Region 2, 4, 6, and 7. And also, I do not want to forget Region 9. Also, in addition, the Louisiana Alzheimer's Coalition developed an online resource tool for coalition use and dissemination through our networks. This training tool helps constituents, families, and caregivers have access to educational offerings. And once this is complete, this will be housed in a depository program with the Louisiana State Library to share among all library systems. Our State Office of Rural Health has worked with our Well Ahead Louisiana Healthy Aging Program to also launch an Alzheimer's disease and related dementia echo series that will start in July, on July 16th. That's to come. Next slide. So the importance of prevention and risk factors, we're going to switch gears. The Louisiana Department of Health recognizes that Alzheimer's disease and related dementias are a significant burden for those who have the condition, as well as their families and caregivers. At Well Ahead, we focus on diseases that are most prevalent, and we look for ways to prevent them and make headway into solving the significant impacts they cause. Alzheimer's disease is often seen as an aging issue. However, people are recognizing it now as a public health crisis. Health always impacts every aspect of our life. Alzheimer's disease not only impacts the person, but also their loved ones, and including our healthcare system. It also takes a stark financial toll on families and our economy overall. Next slide. So dementia prevalence in Louisiana is on the rise for those 65 and older. As you can see in this map, Orleans Parish has the state's highest rate of Alzheimer's at 15.4%, one of the top 10 cities in the nation. Other parishes with high rates include Caddo, Bienville, Claiborne, included in the northwest part of our state as well, East Carroll, Tinsall, and other parishes that you see surround. It is estimated that 94,000 individuals aged 65 and older were living with Alzheimer's disease in 2020. This number is anticipated to increase and grow to 110,000 individuals by 2025. Next slide. So when we look at Alzheimer's disease, and it's not a normal part of aging, we can see connections to lifestyle. Scientists are working to understand its causes and develop effective treatments. More evidence is emerging that healthy behaviors can lower the risk factor for Alzheimer's disease. A CDC study among 31 states of 8 risk factors for Alzheimer's disease, which include high blood pressure, physical inactivity, obesity, diabetes, depression, smoking, hearing loss, and binge drinking among adults 45 and older, found the following. Nearly half of adults had high blood pressure or did not even meet the aerobic physical activity guidelines. Adults with subjective cognitive decline or worsening confusion were likely to have a decline as well. And several modifiable risk factors were more common among African American, Hispanic, American Indian, or Alaskan Native American populations than other ethnicities. Next slide. So in looking at this map, we'll examine cognitive decline risk among diabetes. we can see Louisiana's statewide rate of 13.6% for diabetes. Diabetes is a known risk factor for cognitive decline and dementia. Studies have shown that people with diabetes are more likely to develop cognitive problems than those without. These problems can affect all cognitive domains, especially function and psychomotor speed are often affected first, more strongly than others in the brain. Next slide. So now we want to look at risk factors for cognitive decline related to hypertension. We could see Louisiana has a statewide rate of 40.2% for hypertension. High blood pressure or hypertension is well established as a risk factor for age-related cognitive decline. It can impact cognitive function in several ways. Next slide. And it's okay. So when we look at risk factor for cognitive decline and obesity, we can see that obesity and metabolic disorders are associated with poor cognitive performance. It is also associated with poor adherence to medical recommendations and poor behavior management. Both obesity and metabolic disorders are associated with poor cognitive performance altogether. Next slide. And looking at the map, we could see that the risk factor for cognitive decline among smoking has a rate of 19.5%. Smoking is a well-established risk factor for cognitive decline and dementia. Analysis of a 2008 study found that current smoking may increase the risk for cognitive decline. Quitting smoking may reduce the risk of cognitive decline to levels similar to those of people that have never smoked. Next slide. Now we'll look at risk factors for cognitive decline related to physical inactivity. When we see this map, we could see that Louisiana has a statewide rate of 29.4% for physical inactivity. Physical inactivity may be a risk factor for cognitive decline, as many studies have shown an inverse relationship between physical activity and the risk for cognitive decline. In fact, one study found that sedentary behavior was significantly associated with increased risk for cognitive decline. Next slide. Okay, now we're going to examine risk factors for cognitive decline related to poor sleep. And looking at this map, we can see Louisiana has a statewide rate of 36% for poor sleep. Yes, poor sleep can be a risk factor for cognitive decline. Studies have found that sleep disturbances in older Americans can increase the risk for cognitive decline and Alzheimer's disease. Sleep disturbances can include insomnia, medication usage, sleep shortage, and high sleep variability, which can increase the risk of cognitive impairment. There's also extreme sleep duration, which may cause global cognitive function to decline faster in people with 7 hours per night. Okay. And so in closing, we're going to now hear from Dr. Fountas.
Thank you so very much, Julie, for that very informative presentation today. I'm sure we can all appreciate that pertinent, supportive data that you have provided today. And now we will hear from our second and final keynote speaker for today, and it's Dr. Ann L. Fountas. Dr. Ann Fountas is a New Orleans native and board-certified neurologist with over 25 years of experience caring for people with cognitive and memory disorders. She received her Bachelor of Arts degree in psychology from Wesley College, her medical degree from the LSU School of Medicine in New Orleans, and completed residency and fellowship training in neurology and cognitive and behavioral neurology at the University of Florida College of Medicine in Gainesville. She is an accomplished clinical researcher with over 200 scientific publications and established record of research funding. Dr. Fountas is currently Executive Director of the Brain Institute of Louisiana, Research Professor in the Department of Communication Sciences and Disorders at LSU in Baton Rouge, and managing partner of NOLA Brain and Behavior. Dr. Foundas's clinical practice focuses on patients with cognitive disorders. Her clinical research program is designed to promote brain health through medical research and education. Without further delay, let's hear from Dr. Ann L. Foundas.
Thank you, Tiffany. So it's nice to see some familiar faces as well as new faces. And before we start, I know on a webinar it's a little more difficult than in person, but I want everybody to think first if you're under 55 years of age or over 55 years of age. So under 55 is still considered a younger adult, and older than 55 is an older adult, which goes all the way until over 85 years of age, which is considered the oldest old. And I think it's important because the two risk factors for any type of cognitive decline, including Alzheimer's disease, are increasing age and a family history. But with that said, after sort of all the data that Julie provided that makes us a little depressed about, living in Louisiana, but I'm trying to put a spin on that. There's a lot of interest and effort that, especially midlife between 35 and 55, and it's never too late, that there are disease modifying things that we can do and that our physicians can help well with in terms of treating disorders and disease to help us to age better, including healthy brain aging. Tiffany, if you can advance the slide. So today I'm going to talk about three things. First, risk reduction. Then I'm going to talk about current practices in terms of early diagnosis and treatment, and really the shift now in my discipline of cognitive neurology and in geriatric medicine is towards biomarkers of disease to identify people with a risk to develop Alzheimer's with intervention before they have any cognitive deficits. Next slide, please. So risk reduction. Next. So the cognitive continuum is important. And I think one of the most important things is to understand that this is not something that just develops overnight. And I think it's important for everyone to know that the pathological changes in the brain of Alzheimer's disease, so amyloid plaques and neurofibrillary tangles, are not specific. They're associated with normal aging, just like we get wrinkles and we get age spots with age. But it's that why in some people is there more of that pathological burden at an earlier age, and or that people have earlier onset of the clinical presentation. And so when we talk about this cognitive continuum in the preclinical phase, so these plaques and tangles are oftentimes present and developing and increasing over 10 to 20 years before somebody comes to me with the cognitive complaint and with objective deficits on cognitive testing. When somebody has objective deficits, that means they meet the criteria for mild cognitive impairment, and specifically that they do not have functional deficits. They can still function quite independently. As the disease, any dementia, any cognitive decline progresses over years, typically, the person progresses to meet the criteria and the diagnosis of dementia, which means they are no longer able to function independently. Next slide, please. So there are a number of factors, genetic factors, environmental, and lifestyle choices. Click, please. So what do you eat, drink, or smoke? Click. Do you exercise? Click. How well do you sleep? So those are things you can do. ApoE status is genetic. We'll talk about that briefly. And click again. Traumatic brain injury. So it's been well established that even one mild traumatic brain injury, one concussion, can lower the onset of dementia. Next slide, please. So this is a study from 2015 that I like because it shows the evidence, whether it's strong, moderate, or lower or unclear evidence of what increases your risk of cognitive decline or dementia with increasing age and what decreases your risks or could be protective. Click, please. So I'm going to highlight these four things. So diabetes, depression, sleep-related problems, and high cholesterol, hyperlipidemia. These are four things Julie talked about, how prevalent these problems are throughout our state. but also there are things that you can identify and your physician or healthcare provider can work with you to treat, particularly in midlife. Click again, please. So midlife obesity, midlife hypertension, and smoking are other things that you can do, you can work on, but also your healthcare provider if you need medication, if other things don't work in terms of controlling your blood pressure. Click again, please. Finally, physical activity and Mediterranean diet. There's many, many studies that have shown even walking 10 minutes a day, improving your diet by eating a lot of fresh things that grow on the ground, reducing, red meat and a lot of polyunsaturated fats, if you will, eating more of those unsaturated fats. And then click again. So, and then moderate certain things like your alcohol consumption and don't be socially isolated. Next slide. So you can click through this pretty quickly, Tiffany. So risk reduction, what is the research? So diet, exercise, sleep, stress reduction, social engagement, learning new things. These are all things that you can do to reduce the risk and improve brain health. And I would encourage you all to look online, the Alzheimer's Association, and there are other things too, where they have a lot of healthy tips that you can share with your patients or, your network, if you will. Next. I want to spend a little bit of time talking about sleep. I think it's important to understand more about sleep and how sleep changes with age. So sleep is we spend about a third of our life sleeping. I know when I was young, I thought that was a waste of time. But as I got older, I realized the importance of sleep. And indeed, as we get older, we require more hours of sleep. So really, you should sleep 8 hours a day, sleeping regular hours. So going to bed at a set time, like 10, waking up at a set time, like 6, for example. But about 10 years ago, there was a discovery of a system in the brain called the glymphatic system. So it's similar to the lymphatic system in our body. The glymphatic system in the brain filters out toxins, specifically amyloid beta proteins, those peptides that increased deposition leads to amyloid plaques that we know is associated with unhealthy aging and Alzheimer's disease. So if you have dysregulation of sleep, if you don't have good physiological sleep, not enough hours of sleep, it can increase because these toxins build up during the day and they're normally filtered out while we sleep. But if your sleep is disrupted or abnormal in some way, then you don't have that benefit. Next slide, please. So this slide emphasizes how in Alzheimer's disease, with disease progression, there's a bidirectional relationship with sleep. So as the brain networks become dysfunctional in people with Alzheimer's disease, the sleep becomes more and more disrupted. Many people that are emerging and developing Alzheimer's, sleep-related problems may be an early sign or symptom. But over time, as sleep becomes more and more disrupted with the advanced disease, in turn, it causes more and more abnormal brain changes and amyloid plaque formation. Next slide. So just a minute talking about genetics. So again, we can't change our genetics, but I think it's helpful for people to understand that clinically, as a physician, even though it's somewhat arbitrary, we talk about Alzheimer's as early onset before 65 and late onset after 65. And so early onset is also called familial Alzheimer's disease. It's much more rare. And if you click, please, Tiffany. It is linked to mutations on the presenilin 1 and 2 and the amyloid protein precursor gene. But it's less than 1% of all people with Alzheimer's that have this autosomal dominant. It tends to be in families, so it's really quite uncommon. The much more common form is that we call late onset. But really, if somebody comes to me in clinic and they're 65 or 63, so they're around that change, they have the pathological changes 10 or 20 years before, as we mentioned. And so again, it's really a continuum, but we use this terminology. Click, please. So the later onset Alzheimer's disease is by far the greatest number, so greater than 95%, and is linked to apolipoprotein E. Click again, please. So ApoE2, so there's different alleles and genotypes that we all have. And ApoE2 is protective. ApoE4 is an increased risk. ApoE4 in the homozygous form, so if you get one from each parent, is only 9.6% of the population, but you have a significantly increased risk, 3 to 5 times the rate of developing Alzheimer's. Unfortunately, with some of the disease modifying drugs, so the amyloid infusion therapy, it's known now, there's emerging evidence that people that have this allele are at increased risk for the bleeding complications. So it's a double-edged sword, if you will, in terms of early intervention and treatment. Next slide, please. Just a little more about the ApoE so people aren't too depressed. So click, Tiffany, and then click again. Okay, so the majority of our population, so 64%, are ApoE3 genotype. And that means you neither have a benefit or a risk conferred from this genotype for Alzheimer's. But 25% of people have the ApoE4. And you can see from the pie chart that the majority of them are not homozygous. And again, the ApoE2, which is only 11% of the population, may be protective. Next slide. So in summary, you can click. So lifestyle changes, diet, exercise, moderating certain things like alcohol and smoking, all those things that we do. Health related things, so manage chronic medical conditions. Julie spent a lot of time talking about those things that can increase cognitive decline with age. Treat acute risks, so things like stroke, TIA, vascular problems, so heart attack. Early treatment, so baseline screening and disease modifying drugs. Next slide. Now we're going to shift to diagnosis and treatment. Next slide, please. So it takes a team. You know, we always say it takes a village, but in terms of medicine, it's a team sport. And there are many, many people that are important in caring for people with cognitive decline throughout the continuum. And we have a very, very large rural health population that we need to think about in Louisiana. Next slide. In addition, you have to think of Alzheimer's and other causes of cognitive decline. So it's not all one thing. And so with the exam, the neurologic exam, laboratory tests, and imaging studies are all important. Next slide. So how do you approach a patient with cognitive decline? So the first thing with any patient, you know, as a physician, is the history. And if you can click, please. So in history, the most important thing, is it progressive or is it abrupt? If it's abrupt in onset, then it is more likely than not something that's vascular. Maybe they have stroke or maybe they have vascular cognitive impairment and it's unidentified. In, again, most dementias, cognitive decline are slowly progressive, as we talked about in the beginning of the cognitive continuum. Click again, please. So it's important, click again, in the history to query certain things directly if the patient doesn't answer in an open-ended way. And again, these highlight many of the things that Julie related to in terms of data in our state, things that sometimes can be treatable in people that have a subjective cognitive decline. So they come with a complaint and they have depression or they have a sleep-related problem and they can be treated and they never go on to progress. Or sometimes people come in with, they're still functionally independent, but they have depression or a sleep-related problem. They have a hearing loss, for example. You treat those things, one or all of the above, and the person gets better, never goes on to have cognitive decline. But again, it's important because those are things that are important to identify because they're important in the history. So then when you go down to the cognitive complaint, it's important on the cognitive exam. Do they have deficits or not? So if the person has no deficits, then by definition, the diagnosis is subjective cognitive disorder. It still may be that that person, if they have a family history and other risk factors, and especially with the emerging change of using biomarkers and early intervention, that I would predict over the next 5 to 10 years that many of those individuals have biomarker testing done and have interventions with some of these newer disease modifying drugs. Click, please. So when people have deficits on exam and they have mild cognitive impairments, so they have objective cognitive deficits but are still functionally intact, that's minor neurocognitive disorder. Click again. Major neurocognitive disorder. Click again, please. Yeah. Dementia is the same thing. Major means the person is no longer functionally impaired. So again, a continuum, typically over many years. Next slide, please. So cognitive decline is not one thing. So this shows how worldwide 40% are Alzheimer's, 20% vascular dementia, 15 mixed, 10% frontotemporal, 15% other. In Southern Louisiana, and actually throughout Louisiana, many of the patients I see are mixed. So they have degenerative dementia of the Alzheimer's type and vascular cognitive impairment. Next slide, please. Diagnostic studies are important. Next slide. And the emerging classification schema that we use with biomarkers includes doing a CSF profile and molecular imaging. So PET imaging of the pathological changes I spoke of earlier with tau and amyloid that can be tagged and looked at in vivo, so in living people. And the idea is that individuals will be diagnosed before the onset of the cognitive decline, with the goal that earlier detection will lead to earlier treatment with these emerging immunotherapy drugs that target the Alzheimer's disease cellular pathology, and that early diagnosis should delay symptom onset. Next slide, please. So there's a new classification schema that we use. It's called the ATN, and it's because it's looking at those pathways. So the amyloid, tau-mediated pathophysiology, and neurodegeneration. But it's expanding to include this X, which is additional pathophysiological mechanisms that we know from the scientific literature, from basic science, are implicated in age-related cognitive decline, and newer emerging therapies to target those. Next slide. This is a figure from this reference. And if you look, you can see the continuum. So on the line below, it says preclinical MCI, so mild cognitive impairment, dementia. And you can see the first one is A. So the first biomarker that you see in this timeline is the CSF amyloid. The next is that you see the synaptic dysfunction by FDG or PET or fMRI. The next in the green is tau-mediated changes in CSF. Then you can see brain structural changes, so like volume loss in the hippocampal formation. Then ultimately you see the cognitive changes. So by then the person presents with mild cognitive impairment, and then the progression to inability to function independently. Next slide. This is another timeline that just shows the specific biomarkers. So the CSF A beta protein is first along the timeline, then amyloid PET, then CSF tau, MRI, and FDG PET, cognitive impairment. So again, the idea is that we can use biomarkers to detect these changes earlier, and in people that may be at risk because of a family history and perhaps some other factors. Then maybe in the future, these are people that would be eligible for early intervention. Next slide. And this is an article that was published in August of 22. Next slide. And I like it because it shows, this is a table that summarizes some of those biomarkers that we talked about. Next slide. And this just shows, I mean, again, it's always nice to have some pretty pictures that show amyloid and tau imaging. Next slide. And this is really a figure that I think is helpful and shows where we're headed and highlights something that we can do in our state. And that is with primary care physicians working with dementia specialists, somebody like me, for example, and others, to do first education and really early prevention before 55, if you will. And then biomarker, testing when it's indicated. Next click, please. And then biomarker confirmation and treatment initiation that's done in conjunction, so with the dementia specialist in primary care. And the idea is that we're heading towards the use of digital technology to expand our ability to reach people in more remote places. And next slide. So finally, I'm going to end this section with talking about health disparities. So this was one study that was done in 2021. And I think it's really depressing to all of us to see that some groups, so in this study, Black and Hispanic participants missed or had a delayed dementia diagnosis compared to white people, and that they had a poor cognitive function at the time. So that means they were more advanced, and that proportionally, some of them either never received it or were so late in the process, they maybe weren't able specifically to be targeted for these early interventions and preventions. And our goal in working together with the Alzheimer's Coalition and the Office of Health in Louisiana is to see if we can do more to bring our state up, if you will, to improve brain health. Next slide. Now I'm going to go really fast. So disease modifying, because I'm really out of time. So this is just talking about the shift that we want to change. Instead of talking about Alzheimer's disease, we talk about the pathology based on biomarkers before the person has any cognitive decline. Next slide. And this is the biomarker profile again. Next slide. There are FDA approved drugs. I, was going to spend a little more time, but I won't. There are two things that were FDA approved. Initially, the acetylcholinesterase inhibitors in the 1990s. And then in 2003, the Namenda, the NMDA receptor antagonist that really just treat the symptoms, not the pathology. Next slide. The exciting thing that is really last year, we had two drugs that were fast-tracked. So aducanumab, which is no longer available because of some adverse effect and really not enough efficacy in the a couple of studies that were done. But lecanemab, or Leqembi, which is available. And both of these are following the amyloid hypothesis, which is the idea going back to what causes cognitive decline. But again, it's normal aging. We all hate to tell y'all, but we all have it right now. But amyloid plaques are a defining feature of Alzheimer's disease. They disrupt cell signaling and lead to cell death and eventually cognitive decline, functional deficits, a huge burden on our caregivers, people that we love, and on the healthcare system, like Julie spoke about. But one hypothesis is that if you can get rid of these toxic plaques, you can keep the brain cells from dying and curb cognitive decline. Next slide. So just click through this quickly. Seek medical care early diagnosis. We know some innovative treatment. Keep going. Keep going. Next. Okay. And I'm going to end with this. So this is a study that is looking at the rising tide of cognitive impairment, but it talks about, like I emphasized before, 1, 2, 3. So preclinical stage, prodromal, so mild cognitive impairment, and the syndromal stage. So click, Tiffany. So you can see here in the preclinical phase, the goal is if we can evaluate patients with biomarkers in this phase, then perhaps we can stabilize the mild cognitive impairment so they don't go on to progress down like 3. Click again. Or what about the case that maybe in some instances we can revert to normal? I believe in the next 10 to 15 years, there's going to be, in medicine, we talk about like a cocktail approach. So not just amyloid infusion therapy, but multiple things that are used to target and promote brain health. And isn't it exciting that Louisiana is taking the initiative to do things to hopefully be at the forefront, because that would be the goal. Thanks so much. Next slide, I think, is for questions. Oh, and this is how to end on something positive. So 1 in 3 cases of dementia are preventable. So let's end on something positive before we switch to questions. Thanks so much, everyone, for your attention.
You are welcome. Thank you so very much for that informative presentation this afternoon, Dr. Foundas. I know sometimes it can be quite strenuous to get all of that information, jam-packed into 20 minutes, but we surely appreciate you for joining us this afternoon. And now it is time for our question and answer segment. And I do not see any initial questions in our chat. However, we have some questions for both of our speakers, and we will give both Julie and Dr. Foundas an opportunity to respond to our questions here from our leadership team. First question we will direct to Dr. Foundas. What are some factors that you think are most predictive of successful compliance with Alzheimer's and brain treatment?
I think successful compliance is probably based on the individual patient and probably the family network. So I think there are some patients that I see with cognitive decline, so not just Alzheimer's, that even it could be part of their brain injury, that they're unaware or unconcerned of the deficits, or part of their personality style. So they don't want to admit, and they're very, and even the family network, maybe they're resistant to or embarrassed by the changes in their loved one. So I think having a family network that recognizes and knows how in a supportive way to bring that person to a caregiver. And then I think it's the burden on the caregiver to use the right approach, to be positive, to be kind. So I think those are some of the things that I would say.
Okay, and I will leave the same question to Julie, just in case you wanted to expatiate or expound on that same question. Julie, I will ask you the same question. What are some factors that you think are most predictive of successful compliance with Alzheimer's and brain treatment?
Dr. Foundas touched on I think the head of the nail with it, where families and compliance generally together work toward the successful navigation through the process. I think access to the resources and access to care is a big part of it too. Navigating through the care, as Dr. Foundas mentioned, there are more high risk, high burden populations that do not traditionally seek care. So understanding where to meet people where they are, and then meeting individuals in their space. I know we talked briefly, or Dr. Foundas touched on, we have a high rural population in our state. So coordinating the care in areas that traditionally have low services or services that are not available among families is going to be imperative to definitely stick to compliance and working together. But as a unit, the caregiver and the client, or the actual person affected by the disease, having them navigate the care together because they need to be on the same page. There's many aspects to dementia, from early stage to long-term care. And so each stage is different. And we did touch a lot on the disease process, but there's many stages through that. So working and navigating that as a unit would be successful.
Well, thank you so much again, Dr. Foundas and Julie, for answering that question. Our next question would be, can exercising and dieting prevent people from developing Alzheimer's? Again, that question was, can exercising and dieting prevent people from developing Alzheimer's? I will defer that to you, Dr. Foundas.
So prevention is, I don't know that I can always say prevention, but I can say it definitely can reduce the risk. And when we say reduce the risk, I think it's important, and I think probably everyone that's on this webinar understands that as people live, if you're over 90, more than 50% of those people are going to have cognitive decline and the pathology and the deficits consistent with Alzheimer's disease. But if you look at the goal, which is to push back the age at which somebody at risk has cognitive deficits, and then further back when they're functionally impaired. So they're a burden on their family, and people don't want that, so exercise definitely helps. And exercise is there's a huge amount of research on this. And a lot of times when I do a talk, people will ask, well, what's the dose or what's the intensity or what type of exercise? And it turns out when you look at longitudinal studies of like community dwelling adults that were followed over 14 years, it turns out on average 2 hours a week. So, if you're on vacation, maybe you're walking more, but you're not like going to the gym, right? But I mean, 2 hours a week on average. And so what does that boil down to? So even if you say 10 or 20 minutes of walking, and it is good to do some exercise where you get your heart rate up, that's just good in general. But it's not just good for brain health, it's good for your bone health and for your mobility, because the two things that impact aging are mobility, right? And, brain health, or not the only things, but there's some of the things. And so exercise is good for both of those. Exercise can help because it can reduce weight. And it's not uncommon with all of us that you have midlife weight gain. There's multiple reasons for that. And then that midlife weight gain puts you at increased risk for like you're pre-diabetic, your blood pressure is going up, you're not sleeping well, the kids or adolescents, blah, blah, right? And so, exercise can help because it also helps to improve sleep. So again, those are things that help in terms of risk reduction, and it's better for all around health as we get older or at any time in our lives. Julie, do you want to add something?
Yes, I think you just touched on risk reduction. A big part of why we receive bowl grant funding, which I meant earlier, is to work upstream. We want to look at the individual before they're diagnosed. So understanding, like you mentioned, exercise, that correlates with diabetes management, that also correlates with cardiovascular health. So looking at those risk factors and understanding that if you are affected or you do possess those risk factors, that lifestyle changes can still help reduce your risk moving forward. Women are at greater risk. I believe it was 1 in 5 versus 1 in 9 or 10 in men. And so looking at your personal health and understanding that, the risk increases with age, but understanding how those risk factors involve too, and how we can work toward a healthier lifestyle, incorporating healthy habits. I know, here at our Office of Public Health, we promote the National Diabetes Prevention Program and self-monitoring blood pressure. We also have the Wise Woman Cardiovascular Health Program, where with these programs, it offers resources and individuals can take charge of their health earlier.
Yes, thank you so much, Julie. And that's actually an awesome segue into this next question. Speaking of the workplace, I know that you all may have touched on this a little bit in your presentations, but what are some of the best ways to help manage Alzheimer's and brain health in workplace settings? Did you want to respond to that one, Julie? And then we'll pass the baton to Dr. Foundas.
Managing in workplace settings, Tiffany? Okay, so I'm going to actually give you a little personal dialogue. My father was diagnosed and I was in my early 20s with vascular dementia. I was a working parent, and I was also a working mom, and well, I said parent, but I was also, taking care of a parent. So support in the workplace is imperative. Fortunate for me, my employer at the time had resources that were available, but I feel like as an employer, having resources on hand, I can tell you that, within our state, we have what we call a WellSpot designation program, and we work with work sites statewide. So connecting with those work sites could be very important to the work we do. But I feel like as employers and in the workforce, there's a high caregiver population that handles the burden. So having access to resources for the caregivers, because you look at the actual person affected, but the caregiver's health is at risk too. And they're also in the workforce. So they may have jobs, They may have 2 jobs, they have kids. So it's important to add that layer of support in the workforce environment. And also, on a flip side, offering the workforce specialized training in understanding dementia. That is a big part of what we're trying to push in our rural communities. And I hope I answered the question, because it's a lot you can go with. And Dr. Foundas, if
So a couple of comments. So I think COVID-19 sort of accelerated the use of hybrid models or people working remotely. And I think in many ways that has facilitated, it's a double-edged sword again, because during COVID, a lot of people had more mental health problems because they were more socially isolated. But at the same time, if you have that hybrid model, you go into work and then you work remotely, then you have more control of your time. And I think that more flexibility with work schedules. And I think it depends on what your work life is, what your job is. And I'm all for this idea where, people are talking about longer days, like a 4-day work week, or even a 4.5-day work week. And I think, can you do things like also to reduce stress at work? And I know one of the things that I always have talked about is like, can you have a meeting and instead of like, I know now we do a lot of Zoom meetings, but can you just walk and have a meeting? Can you get up? You shouldn't be sitting at a desk more than an hour. You should always get up and walk around or do something. And so I think anything that people do to move more during the work day, take breaks, be more efficient with your time, have more control of your time. I think the most important thing, and I know I've always had this in my job, I've been very fortunate when I had a boss, is that I had a lot of autonomy, so that I always had someone who was able to help me to achieve a good balance. And so that I could carve out time and be effective at my job, but also have that work-life balance. And, I'm kind of optimistic about the next generation, because I know my children who are in their 20s and early 30s are putting a lot more emphasis on that work-life balance. And I think that's really, really healthy.
Thank you so very much, Dr. Foundas and Julie. Seeing as though we have no more questions, we do have quite a few comments in the chat. So thank you all for chiming in on the conversation on today. I am going to move over. Our Bureau Director, Ms. Avis Richard, unfortunately had to step away for a very high-level meeting. So she did want to say thank you to all of the attendees this afternoon. Thank you very much to our very own Julie Knight and Dr. Foundas for joining us as we talk about Alzheimer's and dementia. On your screens, you will be able to find the contact information for both of our speakers today. You can reach Ms. Julie Knight at julie.knight@la.gov, and you can reach Dr. Ann L. Foundas at ann.foundas@braininstituteoflouisiana.com or ann.foundas@nolabrain.com. Again, we thank you all for joining in today's webinar, and a huge thank you again to both of our keynote speakers, Dr. Foundas and Julie. We are walking away today more enlightened and more empowered. To find out more about Well Ahead Louisiana and our numerous programs and services, please visit us at www.wellaheadla.com, or you can contact us via email at wellahead@la.gov. I know many of you have been reaching out via the direct chat, asking if today's presentation has been recorded and if the slide deck from today will be sent out. Yes, both of those materials will be sent out to all of today's registrants. Again, thank you all and have a good afternoon.